It's my privilege to be here. So I have no conflict of interest. And what I want to talk to you about today are that I have to say I'm a dinosaur in critical care. I've been doing this almost 40 years. It's a long time. And things are really changing. And one of the things that is changing, but I don't have a lot of data to report to you, is the use of EEGs. And we used to use the BIS monitor. It's really not reasonable to use the BIS monitor. It doesn't give you enough information. But we're starting to see studies using EEGs that give you more information and allow you actually to see the state of sedation or anesthesia in a patient. And that's being done increasingly in the OR as well as in the ICU. And we'll talk about propofol, dexmedetomidine, and opiates. I did change the slides based on some recent data. If anyone wants the additional data, just email me, and I will send you the most recent additions. They're very small. Okay, so a recent study from Vanderbilt looked at patients on mechanical ventilation for more than 24 hours. They were screened in all the ICUs, surgical, medical ICUs. They excluded patients who had pre-existing severe cognitive or neurodegenerative disease, who had substance abuse, psychotic disorders, inability to speak, hear, or see. And in this study, they used BIS monitoring to determine the time the patient was in burst suppression. And remember, burst suppression is the state we put patients in who have status epilepticus. It's coma. It's not a state we'd like our regular patients in the ICU to be in. And in fact, it has some implications for prognosis. The clinical assessments were done twice a day for RAS and delirium, as well as looking at the EEG. And they found 124 patients they monitored with BIS, and finally 69 patients were included in this final analysis because they were comatose. And all these patients had 1 hour of burst suppression. The patients who had burst suppression were fourfold increase of post-coma delirium and 22% lower likelihood to have resolution of their delirium. Patients were not in burst suppression for epilepsy, so none of these patients had an indication for burst suppression. So the question I want to ask you is, the way we give sedation now is really based on blood pressure, heart rate, and subjective data by the nurse that the patient's in pain or looks uncomfortable or moves. But if we looked at the EEG, we would be able to determine that they actually were in burst suppression, so they were comatose. Now we have increasing data from the operating room that similarly, we usually give anesthesia based on heart rate and blood pressure or if patients move, but what we are finding is that there's incredible variability among the patients we anesthetize and what we're seeing on the EEG. So young people, infants turn out to have very, very different EEG patterns than adults, and actually that may put them at risk for the effects of anesthesia. But old people have incredibly variable EEGs, and some of the older patients or some of the young patients who are physiologically not in such good shape actually are anesthetized with very small doses of medication. And so what I'm suggesting to you is that looking at the brain may be a more sensitive way to actually assess whether your patient is sedated. And at times their blood pressure will be high, but they will be sedated. So this may be a better way to measure if we're really achieving sedation, and so we won't be over-sedating patients, which we generally do in the ICU. So I don't know if you remember, there was a small study, I believe from Denmark, where they suggested not giving sedation to patients. And they now have, as you can see, they're doing a trial that's all through all Scandinavia, where they're going to have a randomized parallel group, multinational superiority trial, looking at the lack of sedation versus sedation. And I'm very interested in this. They're actually going to look at mortality as the primary outcome. And one of the themes I want to suggest to you today is the amount of sedation we give may actually be instrumental in causing the mortality or poor outcomes of some of our patients. So these patients will be randomized within 24 hours of intubation. They're stratified by the center, age, and shock state the patient's in. They will not be looking at head trauma patients, status epilepticus, comatose, or brain dead patients. The experimental group will not be given sedatives. They will be giving Haldol, okay? So just think about that it may be possible not to give sedatives to patients in the ICU, and they may do well. I will say when I started in ICU, this was the way we treated patients. We did not sedate them. So yeah, I may come back to full circle in my career. Let's talk about propofol. It is the #1 drug given in ICUs. This is a retrospective study that's a cohort study of multi-center ICU database from 2003 to 2009. It's a single ICU admission with mechanical ventilation greater than 48 hours, and they were given continuous infusions within 7 days of intubation. They used propensity score analysis of 13,000 patients. I'll just bring that up that they did not do logistic regression. They found a statistically significant higher probability for ICU discharge, lower risk of ICU death, ventilator-associated pneumonia, less opiates, and less neuromuscular blockade with propofol, okay? Now, I'll just say my personal bias is I always use propofol unless the patient is really sick, doesn't have a blood pressure. So there are confounders that I don't think were fully taken into account here. They excluded patients who had multiple ICU admissions, anyone missing their acute physiologic and chronic health evaluation score, patients who were intubated more than once. They didn't include continuous etomidate, ketamine, or barbiturates, or dexmedetomidine, okay? They didn't include severe head injuries, cervical injuries, spinal cord injuries. Propofol is used, this has been shown in many, many studies. How many of you use propofol as your #1? Okay, yeah, it's the go-to, it's cheap, it goes away. As long as it's your only agent and the patient has a blood pressure that can tolerate it, it's a good drug. Midazolam was used in 17%, lorazepam in 9%. We're talking mostly medical admissions, okay? And they matched propofol use to midazolam and treated. So let's look. In the ICU mortality in propofol treated, the risk ratio, here we go, 0.69. So this looks good. Propofol really looks good in this analysis. Hospital compared to midazolam. So generally, the patients who receive propofol do a lot better than the patients who receive midazolam. Hospital mortality in propofol-treated patients compared to lorazepam is also better. All right, so all these risk ratios are better when you use propofol. And in fact, the day 28 cumulative incidence of death was significantly better in the propofol. I would suggest to you, I do believe there are some confounders. Nonetheless, midazolam and lorazepam may not be optimal drugs, and that there may be some other drugs we need to consider. So VAP was statistically higher in lorazepam-treated patients. Continuous opiates were used more with midazolam than propofol. Propofol really is a good anesthetic, so you need less of any other agent to help you. And neuromuscular blockers were used more with midazolam because people don't move very much when they get propofol. This is Hannah Wunsch, who's now in Toronto. She found that, again, propofol was used 82% of the time, benzodiazepines used 31%, dexmedetomidine used 4%, and the length of stay and the length of stay in the ICU and the hospital were shorter in propofol patients, and the mortality was better. So take it for what it's worth. I do believe there are confounders, but it looks like propofol is the agent of choice today for sedation in the ICU. So a 20-year-old comes to the emergency department with refractory seizures. propofol is increased to 150 mics per kilo per minute, or 9 milligrams per kilogram per hour to stop his seizures. The patient becomes hypotensive, oliguric, and develops new right bundle branch block. Another abnormality seen in this syndrome is it metabolic alkalosis, metabolic acidosis, paralysis, or hypokalemia? This is a question that was on my Yes. So you got it. Okay. This is propofol infusion syndrome. Pediatric practitioners in the PDICU don't use propofol because it's very common to see this in pediatric ICUs. And there's something called the Braid criteria for propofol infusion syndrome that you should know, including bradycardia, hepatomegaly, that your plasma gets lipemic, myoglobinuria, rhabdomyolysis, acute kidney injury, hyperkalemia, and metabolic acidosis. You see this Brugada-like pattern with coved, I will show you these ST changes, arrhythmias, cardiovascular collapse, excess doses, but also short-term high doses or long-term low doses. So if you see metabolic acidosis on someone receiving propofol, you need to be concerned. Here is the EKG pattern that is associated with this syndrome. Okay, you can see the ST changes in V3 and V4 and V5. I will say there's new data on why this occurs, just to give you some of the mechanisms. This is a rat study that was just published this year, and they actually got the rats to die of propofol infusion syndrome. So they sedated them for 20 hours. I dare say I sedate lots of my patients for that duration with increasing doses of propofol, all right? And even in genetically similar rats, there was variability in the outcome. So that's interesting. Propofol accumulated faster in the liver than in skeletal muscles, and they particularly looked at mitochondrial enzymes for their effect. And I'll tell you why. So it looks like propofol interferes with coenzyme Q. And they actually added coenzyme Q to skeletal muscle homogenates and were able to decrease the effect of this propofol infusion syndrome. They then looked at patients, and they found that patients with specific mutations, it's called the Leber hereditary optic neuropathy, the gene mutation that codes for a subunit of a complex that makes patients more vulnerable to propofol infusion syndrome. And with this kind of information, they could even ask you, is this syndrome, this hereditary syndrome, more vulnerable to PRIS? And it is, okay? They found that there were decreases in mitochondrial complexes in patients who developed propofol infusion syndrome. So it looks like propofol becomes incorporated into the inner mitochondrial membrane and interrupts the electron flow at the site of coenzyme Q. So there actually is now a mechanism for this syndrome, and we might be able in the future to pick out the patients who won't do well with continuous infusions or high doses. Remember though, in our world, nothing is sure, and there's a differential diagnosis: septic shock, trauma, refractory seizures, toxic rhabdomyolysis from cocaine and amphetamines, alcohol withdrawal, tetanus, and severe hypophosphatemia can do similar and look similar to this syndrome. And that's a good basis of a question as well. Dexmedetomidine. I want to talk about this. So one thing I don't know if was spoken about yesterday, patients who have acute stroke who come for endovascular care into the operating room, we now use dexmedetomidine. I'm not going to present that as an option because there's not a lot of data, but what there is increasing data of association of general anesthesia with poor outcomes in patients with acute stroke. So if I had to pick a drug that might take over for propofol, it would be dexmedetomidine. What's the correct answer for dexmedetomidine? So I want one answer. Does it decrease delirium? Does it improve mortality? Does it reduce the duration of mechanical ventilation? Is it associated with atrial fibrillation? Okay, so nope, doesn't reduce delirium. It may, but it's not in every study. You can't, there's not a consistent finding. But it does decrease the duration of mechanical ventilation. And it actually decreases atrial fibrillation after cardiac surgery because it causes bradycardia. So let's talk about it. This is an alpha-2 agonist, still expensive, but coming down. It's going to go off patent soon. No to minimal respiratory depression. So it's a very useful drug for things like bronchoscopy or procedures that don't involve a lot of pain. It has some analgesic effects, not a lot, but some. So it appears to reduce oversedation compared to either propofol or benzodiazepines. And I would say we're going to see data coming out of alcohol withdrawal because unlike benzodiazepines, it's not associated with increasing delirium, which benzodiazepines are. It's some analgesia, not as good as opiates, but we'll talk about it. So what I do want to say is for neuro patients, there's increasing data that this is a very useful drug. As I said, we're using it now in the operating room for acute stroke. This is a retrospective study, so not perfect, but it looked at neurocritical care units using a protocol where they compared dexmedetomidine to propofol. All right, these inclusive criteria were 18 to 89-year-olds with neurologic injury. They received 4 hours of IV, a minimum of 4 hours of IV sedation, okay? And this was a 3-year study. Patients who were excluded, and it's always important to see who's excluded, spinal cord injury, vasopressor initiated prior to sedation, so you had a very low blood pressure, need for hypertension, heart block, severe hypotension, as I said, or bradycardia prior to sedation. All of these patients were in the ICU for a very long time, for at least 2 weeks, and the hospital for 22 days. So mechanical ventilation was about 10 days overall. They had a pretty good survival rate, 74%, and 59% had previous hypertension. All right, so 105 patients got dexmedetomidine versus 237. No difference in hypotension or bradycardia. Often the nurses will say to me, I can't use dexmedetomidine, it'll cause hypotension, it'll cause bradycardia. If you use it in the right dosing scheme, and I'll show that to you, it's very comparable to propofol. So they did propensity scoring, and they showed that there was no difference in hypotension or bradycardia between these two agents. This is, we have our belief system, and then there's the data, okay? And the data says if you use the drugs in reasonable fashion, all the drugs lead to the same effect, okay? So here's the data. There's no difference between propofol and dexmedetomidine. So they used low concentrations. I will say that I use low concentrations. If you use high concentrations of dexmedetomidine, you can see an increase in your mean arterial pressure. They don't give boluses. I don't give boluses, all right? And so you can use dexmedetomidine in almost any patient population and get similar effects to propofol, okay? People say, oh, I don't want to use it, it costs too much. Well, if it gets you off mechanical ventilation earlier, that's a big savings. And so some of the problem is just looking at the cost of the drug and not the effect. This was these are 2 reports that you can actually show if you look at the overall cost of care, including the days on a mechanical ventilator, the days in the ICU, dexmedetomidine makes sense. And I will say my pharmacist, maybe he's given up, just gives it to me when I ask for it now. So it seems to have the same effects, at least in neurocritically ill patients. I dare say comparisons could be done with other patients. Bradycardia is something people focus in on. I have seen bradycardia with it, so it's a real phenomenon. You have to be careful. But it has the advantage that it keeps your patient more awake, and we call it extubation. We routinely use it in our younger patients who are, what can I say, more agitated to get them extubated, all right? So it's a really good drug to calm people down, and actually overall costs seem to be similar to other drugs. Let's talk about opioids. You know, the United States has a problem. 80% of all opioid prescriptions worldwide are taken by patients here. That's ridiculous. And so again, there's a belief system that's, I would say, came after I initiated my training in ICU, that everybody had to have a continuous infusion of opioids. And now there are more deaths related to prescription opioids than to deaths from cocaine and heroin combined. The fastest growing heroin addicts in our country are suburban housewives who find it cheaper than prescription opioids. So we need to think about what we're doing in the ICU, because I want to suggest we use more opioids than almost any other group in the hospital. You need to know there are 4 opioid receptors. There's the mu delta kappa and the ORL1, just to be very specific. The mu receptor is where we like to attack. We use almost exclusively mu opioid receptors, but kappa receptors, we do have drugs that will go there. 1 in 20 people in the US are on opioids. I tell you this because the science of opioids is increasingly being investigated, and I think there's a very nice review in the Mayo Clinics that just came out in July. So it actually has effects both pre- and postsynaptically. It inhibits calcium channels, so you see a reduction of substance P and glutamate, but its postsynaptic effects actually hyperpolarize cell membranes by opening potassium channels. So the reason this is important, if you continuously give opioids, you see these effects, and you can see hypersensitivity, which we'll talk about. What you need to know is the central effects, because there are drugs that will block the peripheral effects. So what are the central effects? All of these are central except one: nausea, cough suppression, urinary retention, hypotension, meiosis. Which one's not central? There are several drugs now that will block the effect of peripheral narcotics. Yes, urinary retention. It's a peripheral effect. The central effects are analgesia. So if you block peripheral effects, you still get analgesia. Nausea is central. Sedation, respiratory depression are central. Hypotension, meiosis, cough suppression, rigidity are all central. So you can block the peripheral effects. You will not affect any of these. Constipation is the one the surgeons look at a lot. Urinary retention, hives, itching, flushing, and immune effects. And there are a lot of immune effects from opiates. So I'm going to go through this rather rapidly. You have them. Basically, I want to suggest to you that the data in animals suggests to treat pain, you need very small doses of opioids. And there are different places in the brain for pain relief versus addiction. And what they've shown over and over again is that in animals, small doses treat pain. But when you get to larger doses, now you're getting rewards, not for pain relief, but because you've hit a part of the brain that likes the effect of opioids. And so we overuse opiates incredibly for pain, and with continuous infusions, you're, I dare say, not treating pain, you're treating reward. So you need to be aware that small doses of opiates are all you need for pain. And patients who are tolerant to opioids present incredible problems for us, okay? And what data has suggested is that they become very sensitive to particular kinds of pain. And this study, which you don't see the reference, but hopefully it is in your handout, that actually you get altered sensitivity to thermal sensitivities, so it doesn't take much to give them pain. And the trouble with them, with chronic opioid patients, is you can't satisfy their pain relief with opioids. So you're going to have to use substances that affect other receptors. And you've created, with chronic opioid use and continuous infusions, hypersensitivity, hyperalgesia. So you've actually not only not treated their pain, but you've made them more sensitive to painful stimuli, and they can actually be in pain from overdosing on opioids. So I have residents who love remifentanil. It's very expensive. Here's prospective studies, randomized controlled triple-blind studies that compared fentanyl to remifentanil. They use validated pain scores, protocols, and propofol, not benzodiazepines. The duration of ventilation was about 6 days, and they used protocolized sedation and analgesia. And they found that they could get superior analgesia and less opiate administration with this protocol, and that there was no reason to use remifentanil. Okay, so just to go back, remifentanil was no better than fentanyl. And remifentanil actually has a higher incidence of hypersensitivity. So patients, even in the operating room, can become tolerant to opioids if you use remifentanil. It's so strong, and it sticks on the mu receptor so well that you can see the phenomenon of tolerance and actually hyperalgesia with remifentanil. So I generally don't use it. It's a good drug, but only for certain things. I will say things you need to remember are there certain procedures that cause pain in our patients. This is a nice study that was in the Blue Journal last year. This is Catherine Puntillo from UCSF. She did a prospective multi-center trial that was international. She showed there were 12 procedures. She looked at 12 procedures. And most of these, about 40%, were on mechanical ventilation. During all the procedures, she found an increase in pain. But the worst was arterial line, okay, drain removal that our surgeons do, or chest tube removal. And things you should think about is when you're putting in the arterial line, use local anesthesia. If you're removing, you can actually use ketorolac or lidocaine injections to help with the pain. You don't have to always give opiates. There are adjuncts to pain that I would say are actually superior. So we need to limit sedation and pain medications. We don't have a really good way of even measuring if our patients are anesthetized. That's coming your way. I think EEGs will be used more, particularly in our patients who require prolonged mechanical ventilation. I highly suggest using patches. There's a new cream now with a non-steroidal cream that can be used. Our patients are not all the same. Elderly patients, very sick patients, have different brains and require smaller doses of sedation to be sedated. You need to know about propofol infusion syndrome. It's worthy of questions. And continuous infusions of narcotics, we're actually looking at the doses that people get over time in our ICU, and they're outrageous, okay? 7 days, continuous infusions always go up because patients become tolerant. You can't imagine how many opiates are cumulative in your patient. And then what is the downstream effect? What's the long-term outcome of those patients? Those are issues we need to face. And with that, thank you very much.